Well, welcome back, everybody. It's 20 after. I think we want to go ahead and stay on time and introduce went from one really good panel to another one. So I know everybody's going to find this very interesting. Culture change is always a tough topic. The moderator for this panel is going to be Kara Feldman-Hunt. She's a program manager at UVM Integrative Health, vice chair, policy working group, academic consortium for integrative medicine and health. And we're fortunate she was available today, although I think everybody's sort of available more these days since we're all stuck home or grounded from traveling. She's been involved in the field of integrative healthcare since 2008. It's probably not an easy time for her pushing this forward, so we appreciate her staying with it. As administrative director of UVM Integrated Health, she works with leadership in the College of Nursing and Health Sciences, the Larner College of Medicine, and the University of Vermont Medical Center to develop sustainable program for clinical education and research activities. No small task. Her background is in organizational development. It's sorely needed in this environment. She's working with large corporate settings, small startups, nonprofits, and educational institutions. Prior to joining the UVM team, Kara served as executive director for the Laura Mann Center for Integrative Health, bridging the gap between community members and health practitioners from all disciplines, something that's serving her well today. She's currently enrolled in the Functional Medicine Coaching Academy, and I'll turn it over to you and look forward to hearing about the great work.
Great. Thank you, Kevin. Hi, everyone. Nice to virtually see you all. We're excited to be here today and share with you a little bit more about our program. But first, I wanted to give you just a snapshot of the Vermont landscape because I think our story is important. We have a strong community and interest in integrative health and medicine in the state of Vermont. It's a friendly place to practice. Folks can practice at the top of their scope here, and the use of complementary and alternative medicine is relatively high. Alain Langevin, who many of you know, now is the director of the NCCIH, and she started a program at the UVM College of Medicine in the early 2000s with a group of other researchers and clinicians. While mostly the program was research-based, there was a handful of people who were determined to bring integrative health and medicine into the UVM Medical Center. At the same time, there was a growing list of pain patients waiting to get into the mind-body medicine clinic. Unfortunately, that clinic has since dissolved and left patients without many options. A culmination of a decade or more worth of work at the university and a partnership with the local nonprofit that I used to work for, the Laura Mann Center, we started the next iteration of UVM Integrative Health. We formed this new program in 2015, which is a collaboration among the UVM College of Nursing and Health Sciences, the Larner College of Medicine, and the UVM Medical Center. At the same time, the medical center was identifying a need to respond to the opioid crisis, much like the rest of the country. They brought together a team that included representatives from family medicine, anesthesiology, psychiatry, and integrative health. Together, we developed the comprehensive pain program, which you'll learn more about today. Also, during this time, a broad opioid bill was passed by the Vermont legislature. Among the many important pieces of the bill, two were particularly important to our story. The first was to fund a study on acupuncture for chronic pain in the Vermont Medicaid population. This study was funded by the legislature and led by Robert Davis, a local acupuncturist and former co-president of the Society for Acupuncture Research. The other important piece of the bill was a request to Blue Cross Blue Shield of Vermont for a literature review on acupuncture for chronic pain. Robert Davis saw an opportunity to use the latest acupuncture research data to collaborate with Blue Cross Blue Shield to update their report. Vermont's a small state. We can pick up the phone, call our legislators, policymakers, and healthcare leaders. This is how Robert Davis and Josh Plavin, Medical Director of Blue Cross Blue Shield of Vermont, connected. You'll be hearing from Dr. Plavin during this panel. This connection to Dr. Plavin started the conversation of our bundle at the Comprehensive Pain Program. I hope our story inspires you to reach out to your policymakers in your state. Dr. John Porter, Medical Director of the UVM Medical Center Comprehensive Pain Program, will kick off our panel today and provide an overview of the program's development, framing, and structure. Okay, go for it, John.
Great, thank you, Kara. Delighted to be here. And I want to just express appreciation to the staff and leadership of the Alliance for putting on this offering in the midst of a pandemic. I know it's been a tremendous amount of work, so we appreciate it and we are grateful. I have no financial disclosures to make. I was thinking that if I had any disclosures to make, it would be that I badly need a haircut at this point, but I hope you will not dwell on that. Next slide, please. I'm going to just spend a few minutes talking about the program, and I'm really going to focus on an overview of the program. Kara's talked a little bit about the genesis of it, and I want you to have a sense of the work that we have been doing up here in Vermont and some of the lessons that we have learned and are still in the process of learning. Next slide, please. So in terms of what's informed our framing of the work here, I want us just to step back for a moment, and many of us are intimately familiar with the experience of chronic pain, either through our work or through our personal experience. But what does it feel like to be someone who experiences pain as they go through every step of their day, whose affliction is invisible to others, whose sense of self and identity has been transformed by the experience of chronic pain in terms of vocation, sense of worth, role in the family, role in their social circle, who are isolated as a result of that, who are disproportionately the victims of physical, sexual, and emotional abuse or violence, who disproportionately inhabit lower socioeconomic status in our society, and who are more likely to experience serious psychological comorbidities, including depression and anxiety. And so for our framing, carrying that and working with folks, and we often see heroism every time we meet with them. The framing for chronic pain for us really has to do with, are we making the right diagnosis? Is the language the best that we can choose for this? So if I step off the curb this afternoon and break my ankle, I will have pain, and the ER doctor will tell me you're having pain, and I will agree with that. But if we talk about the entity of chronic pain, we have tended to treat that as pain that goes on a long time, right? And we know from the experience of these individuals who are working every day like this, that doesn't capture the experience. And so that informs how we approach folks who come to us for care, that maybe chronic pain is well used. It has value in lots of different ways to quickly describe the experience. But in a much more global sense, this is a form of suffering, right? And the positive thing about that is that suffering is universal, it's human. It also provides openings for us for growth, for good things coming out of the experience of chronic pain. And as we change that diagnosis from one of just chronic pain into one of pain that exists, but it has a whole 360 degrees of experience around it, that offers us therapeutically lots of different options and approaches about how to work with that to help people obtain, optimal comfort and function in their lives. Next slide, please. So I'm not going to spend much time here except to say that I came here as medical director in December of 2017. The spring, summer, and fall were extremely busy in lots of very positive ways with the renovation of a building, which is 8,500 square feet, and assembling a team of very skilled individuals. Next slide, please. I want to just touch base about what the bundle is, which has been worked on with Blue Cross Blue Shield and the Medical Center, and Dr. Plavin in particular in that leadership role. So from the participant experience, individuals who come to this 8-week program paid the equivalent of 2 primary care copays, one at entry and one at 4 weeks, which is the midpoint of the program. Everything else that we'll be talking about today is covered under that so-called bundle, and you'll hear a bit more about the therapies as we move forward. But that was a huge issue as we started to develop the program. If people are here 2, 3, 4, 5 days a week sometimes, how do we pay for that? How do we get the co-pays? How do people manage that? And that was a tremendous barrier for us that the bundle has solved. Next slide, please. So what are some of the dynamics? And I think you probably can imagine some of them. For the medical center, a brand new model of care compared to what we had been doing with folks with chronic pain, large organization, lots of cultural inertia, kind of blurry reporting lines, so that I sit quarterly with a group of chairs from psychiatry, anesthesiology, family medicine, and the vice president of medical operations. I'm a family physician who sits in the Department of Psychiatry. For the staff, that process of coming together, building trust among individuals with great expertise, but who really don't know what the other one can do yet as they come together. The issue of trust, issue of territory, but imagine being an integrative clinician, Dr. Khan or Robert Davis with acupuncture, having been practicing outside a system like this and coming in and trying to enter that without some degree of skepticism and mistrust is a real challenge. And then for the folks who refer to us, the primary care clinicians in the medical homes, lots of education about what the program will involve, a pretty consistent disappointment that the program is consultative in model, and that we are not just going to take these folks over and work with them for the long term. So lots of dynamics, lots of things happening that are swirling around as the program's developing. Next slide. So we've talked a little bit about the experience of folks with chronic pain. And the fundamental question for us as we developed the program was, how do we create an environment where participants can be seen, believed, held safely in an environment that provides room for reframing, re-envisioning their experience with chronic pain, allows for personal growth, and helps them find openings for moving forward. And so in the program, the patient really is at the center of these three entities. One is the group experience, which provides them with a tremendous connection and sense of community over their time with us, and is a powerful therapeutic tool. The transdisciplinary team is just that, it's transdisciplinary. This is not a program where people come in for 3 half-days a week and do acupuncture and massage therapy and leave. Every week for 90 minutes, we have the entire team, which may be 12 or 14 people, sit around our case review table, and we go over folks coming into the program. We look at each cohort at the midpoint in its experience, and we discuss participants who are having a tough time in the program and figure out ways that we can work with them. And the approach is comprehensive, so that it does involve truly body, mind, and spirit. Next slide, please. Just a quick shot of our movement room. This is Erin Bingham, a nurse practitioner who practices 2 different kinds of yoga and movement with participants. Next slide, please. And just a quick look at our foundational values. These are generated by our team. And they say a lot about how we approach each day in the work, both with the individuals who come here, but also as a team. How do we work with one another? And I want to highlight the last item, which is self-care, right? So in a place where there's a lot of suffering, where people are having a hard time and navigating challenging new material, how do you take care of the folks who are working there, who are your primary therapeutic agents, all right? So lots of attention given to that part of our work. Next slide, please. In terms of the goals we have for folks who come to the program, well, at the foundation, we want everybody to come and be optimized in terms of what's happening with them medically, either in terms of medications or interventions. We want to make sure that that is solid. We want them to be exposed to and engage in new and different therapies that they haven't been able to access, usually because of financial considerations. And we want them to leave the program with an optimized sense of self-compassion, resiliency, and self-efficacy in taking on the work of managing their chronic pain. So the corollaries for those coming out are increased comfort, increased level of comfort, of function in life, doing the things that they really want to do. And at the beginning of the program, they identify and articulate between 1 and 3 realistic goals that they'd like to work on during the program. And we want them to have made substantial progress towards that. Next slide, please. In terms of the structure of the program, it's 8 weeks in duration. It's quite intense. It's a closed cohort, so people really do get to know each other very well during the process, during the program. Each individual attends 2 group sessions each week. One of the group sessions is a group medical visit, and the pillars on which that is based includes spirituality, self-compassion, mindfulness, and movement. The second group session each week is based on acceptance and commitment therapy. That is run by our psychologist, Dr. Heather Finley, and that involves clarifying your values and acting on them in a stepwise fashion to achieve them. That first group medical visit is co-facilitated by me and by Laurel Audi, who is a nurse and also our Reiki clinician in the office. Next slide, please. Just a quick view of our kitchen. This is our chef educator, Leah Pryor, with a group. And so cooking and nutrition is part of the core curriculum. And then around that, there are also classes that participants can attend throughout their 8 weeks. Next slide, please. These are the structures that are available to folks who come to the program. I won't read them off, but it is a wide array. They involve both individual and group offerings. And I just want to make sure that folks know that beyond that, people have access, the participants have access to an ongoing alumni group, which at this point meets twice each week, which is run by both a nurse practitioner and our social worker, provides ongoing support for these folks as they go back to their medical home. As well, the primary support individual, which could be a spouse, could be a child, could be a neighbor, whoever works most closely with folks in terms of going through their day with their experience of chronic pain, is invited to attend the orientation. And then 3 times during that 8 weeks are invited to a group, because we want to make sure that the home system knows exactly what's happening in the comprehensive pain program, so that there's growth there, and there's also support for those individuals who are working every day with their loved one. I think that's where I'll stop for now. Next slide would be great. We do have a video that we'd like to show, which will give you a sense of the tone of the program and the experience of some of the folks who have come through, many of the folks who have come through. So I'll step back and let that happen.
I found the PATH program from receiving a mailer from Blue Cross Blue Shield, and it happened to dovetail with a point where I had kind of pursued all of the options I could come up with your traditional medical settings, with going to surgeons, an orthopedist, my normal doctor, physical therapy for years.
So many of us that have walked through this place have been to so many different doctors, and it's a lot of tests, a lot of medications.
There are dark times in all of our lives.
I was unable to get off the couch most days. I was unable to walk my children to the bus stop one house over. I had no longer been able to do chores around the house. I could not find a path forward for how I would live an actual life. And after going through the PATH program, it's like I got my entire life back.
What's different about this program is the caregiving, the concern, and the hand-holding that we get.
I think we're through the darkness.
There were so many components that were looked at. People not only got it, but they had empathy, and they were willing to try to open up ways to work within pain and help people and not just give them pills.
They provide us with enough space to feel what we need to feel.
Being involved in the PATH program was the first time I've ever been in a group setting for anything medically or therapeutically.
At first I thought, what are we going to do for twice a week, sitting together, the same people, but the dynamic of our group was powerful.
We kind of instantly bonded. You had people to root for, you know, and people that were rooting for you, and that's everything.
It's so helpful to just have other people who realize that it's a constant battle.
And that connection and that community feeling, it made me feel normalized instead of marginalized. And that's huge when you find a group that you can talk to and be vulnerable, that will also lift you up. So there's a lot of work that you do during your time doing the program at CPP. We did this game plan. You basically break your goals down based on your values into small manageable things, and it's really nice because it's all structured for you and you don't really have to think about how to do it in the same way you would if you were on your own.
Everything you offered, I wanted to try. Some helped me a lot and maybe some weren't a great fit, but when I would talk to others in my class, what was good for them might have been different than for me.
There are a ton of integrative therapies available. There was massage, which I really enjoyed. Massage therapist here is very skilled with tailoring it to what you need.
There was nutrition classes, there was information on the medical marijuana, there was Reiki. The classes were wonderful. I think it kind of made me a little more zen and a little more, less confrontational with my pain. Like, you know, it's still a battle, but it doesn't have to be a war.
I also feel like I can see the light in the day now. Like, I can see how pretty it is out when it snows, and I can see all of these things that when I was wallowing so deep in my pain and not feeling like I had any solutions or options, I just couldn't see them anymore. And after being with CPP, I definitely am a more positive person again. I can find solutions, and it's been amazing.
This program has just gripped me by the hand and is walking by me when I am going through all this treatments.
It gives you a sense of the tone again and the experience for folks as they come through. And I would now like to hand the proceedings over to Dr. Josh Plavin, who is the Medical Director, Chief Medical Officer, and Vice President for Blue Cross Blue Shield of Vermont, and who has been just an outstanding, wonderful colleague in helping us develop the program.
Thanks, John. Yes, I first, I don't have any financial disclosure other than I work for Blue Cross Blue Shield of Vermont. I am a primary care provider and still provide some care as well in local facility. And just want to reflect on kind of the journey that started parallel to Robert Davis and was kind of catalyzed by Robert's call. So next slide. Thanks. So from our perspective at Blue Cross and Blue Cross of Vermont, and just to remind people, the Blue Cross is an association. There are 36 Blues across the United States. They're all independent. We're an example of a single state nonprofit focused health plan here in Vermont. So, you know, the kind of framing up the problem for us was we had 100 million American adults who have chronic pain, and we had a large portion of our population, somewhere around 5%, who are living with chronic pain of our membership. We knew that 40% of all adults had chronic pain. We knew the prescription rates. We knew that, and I've been involved in a lot of the opioid mitigation strategies throughout the state. So we knew 20% of abused opioids are prescribed for the individual, while 72% are sourced from friends and relatives. And some of the work that was a motivator for this was born out of the opioid epidemic. So 38 deaths in Vermont in 2016. And then the issue of 30% of patients on opioids for chronic pain and substance use disorder. So next slide. So as part of that, opioids were identified as really not appropriate for chronic pain, and really were while they had a place in care, perhaps not the best care or the best sole care for chronic pain. There was interest and activity at the state level through the Governor's Opioid Coordination Council that focused on non-opioid alternatives, with specifically focus on other modalities such as acupuncture, exercise, CBT, etc. And so we had already been kind of thinking about how to address this issue. In addition, we are in, and we still are in, the transition from fee-for-service to value-based payments, and with, the foot in either canoe. And kind of the fee-for-service structure discouraged alternative and integrative therapies, team-based care, case management, and a survey of our physicians in 2012 from the Medical Society, the quote was, "Physicians feel stuck," and interestingly, COVID-19 is creating quite a motivator to move over into that canoe. And then our members and patients were finding few available alternatives, as you heard through the video. Next slide. So for us and for our clients, musculoskeletal disease conditions were the #1 cost driver for all of our commercial clients in Vermont. And that's pretty broad. That includes things like high-cost pharmaceuticals. It includes interventional procedures. It includes advanced imaging around that. It also includes rehab and chiropractic care as well. And so we're focused on that regardless, in terms of controlling cost and improving quality of care. In addition, this concept that workers with musculoskeletal pain lose 5.5 hours a week of productive time was a big issue for employers. And then we also knew that in general, not just for musculoskeletal, but for all chronic conditions, as much as 20% of our members had co-occurring mental health and substance use disorder diagnoses, and generated 40% higher cost on the medical side when they had co-occurring conditions. And in Vermont, we call it mental health, substance use disorder, not behavioral health, just to say that. Next slide. So we developed an overall strategic plan, and the goal was to work with our providers in Vermont in partnership to develop a new approach to care. And out of that was born the concept of a comprehensive integrative pain program, both in partnership with UVM, but separately from. We had already started to think about that and had started to plan for that at the same time. So it was a bit of a we hit the zeitgeist. We believed that the way to pay for this was through an outcome-based bundle, move to value. And we saw this as a test bed for a center of excellence approach in support of integrative care. The concept would be, and the issue is that there is one center in Vermont right now. We would love for there to be 6 centers in Vermont spread across the state to create access for patients. So, driving 2 hours from Brattleboro to Burlington is really not in someone's interest, particularly if they're going several times a week. So the goal was to expand to what we call health service areas. We have 13 in our state. Develop a clinical model, a payment model, an education model, and then a training model. So a much broader goal here, and to some degree, we are kind of at the end of the beginning right now, with a lot of work to be done to kind of scale this and learn from where we are. We felt that the integration of mental health substance use disorders was foundational to this work, and therefore the clinic should be centered around a primary care focus through folks like Dr. Porter, and a mental health focus through folks like Heather. It's kind of a midfielder between primary care and interventional, and a piece of a continuous system of care, which we're continuing to talk about and comment in a moment. And then, helps to address that MSK issue, right place, right care, right time. We feel from other research and kind of pilot projects throughout the country that from a kind of a ROI perspective, we would be able to drive down costs in interventional procedures and advanced imaging by up to 20% for this focused population, as well as perhaps decrease opioid use, and then create a high quality, highly accessible point of care for our members and really for all patients in general, both from a secondary prevention, but also much earlier in the disease process, and perhaps even at the point of even starting to think about, gee, I wonder if this patient has chronic pain, maybe we should enroll them with the program. So next slide. So, as I sat and thought about this, it was valuable to clearly identify the problem and its impact from our perspective so that I could explain it to all of my internal stakeholders, and there were many. I had to convince the finance folks, the actuary folks, the quality folks, et cetera, et cetera. So there's a fair amount of work that goes on, even within your own four walls, let alone outside with external stakeholders. Finding points of shared interest and then kind of expanding on those in terms of goals, both internal and with external stakeholders. If possible, finding supporting research and models, and so we found some of that. There's not a huge amount out there, but there's a fair amount. Finding the willing audience, and really just change management. You can't, there's never too often to have this conversation, bringing it up one-on-one, both informally and then in more formal groups, many times over time. And I can say, I started to talk to Kara about the program 2 years before we actually put it into action. And so it took that long to kind of get this off the ground. And building that relationship through open, honest communication and meaningful and timely action, being accountable to action, following through with things, and then working together, recognizing where you have opportunities to improve, where something didn't work and you need to change it, and being open to that partnership. Next slide. So everyone's interested in the bundled payment focus. So we'll dwell on that for a moment. It's one payment path for the future. There's all sorts of things. There's population payments, global payments. Our goal was to create the flexibility for the providers to provide high quality care. And in terms of how you build the bundle, there are various ways one can do that. You can borrow it from other organizations. You can come up with it internally in a proprietary fashion, or you could do what we did, which was we just partnered with the providers and said, okay, what do you want to do? How long do you want to do it? At what level of intensity? And then we'll kind of scale that up from what we know is the fee-for-service schedule. We'll fill the goals and negotiate rates for things that we don't or have not covered in the past. And we'll just intentionally hold each other accountable and revisit the utilization, which we're actually doing right now, to see if we need to adjust the bundle. Do we need to pay you more because the services aren't covered? The cost of the service of what you're providing is not covered, assuming that the outcomes are good. And put as much into that contract and hold each other accountable within that trusting relationship. So it's a very positive, trusting relationship and not a kind of suspicious, mine or yours kind of relationship. It's ours. So next slide. So this is just an example of the spreadsheet that we threw together. actually that John and his team threw together. And we use that as a working model to kind of build that bundle. And so you can see, and this is just one small cut of it, and it's an early draft. But the assumption was 8 weeks. It would be billed monthly times 2, as Dr. Porter mentioned. Here's an example of some services that we expected with an expected utilization over the 8-week course, and use that as the foundation to build the bundle. A lot of work between our contracting legal counsels and the provider contracting folks as well, but they have a very good working relationship as well. Next slide, please. So the other piece to this, in terms of kind of the question of, is this worth it, and can we scale it? Can other Blues do it? Can we even convince other providers to do this work? Because we have to do research, and so we have a policy of coverage with evidence determination. The concept is the program is an active lab, and that this is an area where we both agree there's the hypothesis is there's a great deal of opportunity and impact, and so let's study it together. Our study would be focused on outcomes which are meaningful to patients, so human-centered, patient-centered, functional outcomes with PROMs, patient-reported outcome measures. And we were going to study the claims and a cohort comparison to track utilization and identify potential savings, and we thought the hypothesis was that ER utilization would drop, interventional procedures, medication costs, mental health utilization, adverse utilization, not positive utilization, if you will, would be reduced. And we are in the process of studying that now. And then we'd like to publish those results in, if successful, plan to sustain and spread. So kind of that's where we are right now. And I just want to share with you some initial results. So next slide. I think that's this. Yes. So, and this is just our results on the claim side. Dr. Khan is going to share with you the clinical results to date. But so far, we've had 32 members who have completed the program as of January 22nd. And we looked at, and this was a pre-post, so not quite the cohort yet. Small numbers, not statistically significant, just looking at trends now early on. And, we did see per member per month that was slightly increased post, but I'm not concerned about that necessarily because we don't know if that's good or bad utilization, right? We just know it's more. So we'll have to study that. However, and again, not statistically significant, but the ER visit rate per thousand decreased substantially. There were, 500 to 0 pain-related ER visit diagnoses in this cohort, and then overall went from 937 to 184. So obviously a very exciting and positive trend. The utilization of some medical services before and after acupuncture, obviously many of these patients did not have access to acupuncture before this, although probably half of our membership has access to acupuncture through kind of a self-funded benefit that we make available. But that drastically increased. The folks who, no big change in dietitian visits, chiropractic visits decreased somewhat. So these are trends which we would want to follow over time. Very early, not definitive, but just wanted to share with you what we know as of this moment. I think that this is the end of my slides. I'm going to pass it on to Dr. Khan to talk about the other research and our focus there. Dr. Khan is a research assistant professor at the University of Vermont College of Medicine. She is an esteemed and renowned health services researcher across the United States, probably best evidenced by the fact that President Obama announced the appointment of Dr. Khan to serve as a member of the advisory group on prevention, health promotion, and integrative and public health in 2011. She holds a BA from Antioch, EDM from Harvard Graduate School of Education, and a PhD from our shared alma mater, Brandeis University. So I'll pass it on to Dr. Khan.
So thank you so much, Josh, for that introduction, and and also thank you to Amy and the whole team for persevering through this pandemic. I want to say that I kept the title of the conference on this opening screen just really to emphasize the issue of innovation and what an early stage we are in as a program. So this has been it's been a process of constant learning for us, I would say. And there's a way in which, you can go to the next slide now, there's a way in which creating a new program and being open to what you're learning and trying to conduct research on it at the same time is sort of a very strange relationship. And so what we know is that innovation being a process of ongoing learning, you know, with the key goal of wanting to provide the best possible care you can to these people, means if you learn that something could be better, you want to change it. And on the other hand, clinical research, of course, requires, brings with it a certain tendency toward rigidity, because if you want to assess whether or not a certain intervention had important outcomes, you want that intervention to stay stable. And we were not. So keep that in mind as we go along, and take me to the next slide, please. So I want to say, and Josh already somewhat alluded to this, just that at the time at which we were deciding what it is we needed to look at for this program, there are multiple stakeholders of interest. Blue Cross Blue Shield was certainly one, and obviously the total use of healthcare services, even apart from or in addition to this program, was a matter that they were interested in and that they could look at, which they already have. For the leadership at University of Vermont Medical Center, they of course have their own interests, which is this program going to be serving our chronic pain patients at least as well as the things that we were doing before, or not? Is there any chance that it's going to improve it? If it looks good, is it actually going to be sustainable for us? Are we going to be able to afford to do this? They had, as you saw through the building that they built, put in some, made a serious investment in the program. So they're keenly interested. And as Josh said, the Vermont, or maybe you didn't quite say, but sort of alluded to, the Vermont Department of Health Blueprint for Health was actually planning to launch a hub and spoke model and test a hub and spoke model for pain management, chronic pain management in particular, across the whole state of Vermont, as they had already done very successfully developed a hub and spoke model around opioid addiction treatment in the state of Vermont. So we had in mind, as we developed this, the interest of all the potential other centers as well that would be evaluating their programs, and kept that in mind, looking at what measures we should use. And then of course the clinicians, our key interests were about the patients and also the patients' families. You can switch to the next slide, please. So what we, oh, these all came at once. Okay, so these are the things we decided to look at. In terms of program components used in an evaluation of any new program, of course, the key question is, if we build it, will they come? If we give them a program with a whole lot of choice in it and many, many therapies available to them, will they use it all or not? Or what will they use and how will they make those choices? And then Josh looked at other services used. We certainly wanted to look at pain levels and the issue of pain interference in other aspects of life. And for that, we were using the AACIPM model that you can see at the right, pain scale that you can see at the right. And then a core was our decision to use Promise 29 that looks at 7 different items across the domains of physical, mental, and social health and well-being. And in addition to those, we added a resilience scale and we added a self-compassion scale. Okay, we can go on to the next slide. I want to say a little something, a few words about pain in general before we go on. And John spoke about this, I think, quite articulately, so I'll try to be brief. But pain is not just pain. There's more than pain going on for anyone who's been living with pain for a while. And in 1955, Dame Cicely Saunders, who worked with terminally ill cancer patients in London, coined the term total pain and said that it includes physical, emotional, social, and spiritual distress. In 2010, Walker and Clark and Sanders coined the term post-deployment multi-symptom disorder to describe what they saw in veterans who were returning from Iraq and Afghanistan. And if you look to the lower right in that polytrauma P3 triad, what you see is that people returning from Iraq and Afghanistan, and this is a population I've worked with pretty intensively myself, were returning with pain, that's the lower left circle, but also with PTSD, and then also with persistent post-concussive syndrome. And fewer than 20% of the people returning had only one of those P's going on, only one of those things going on. And 42% had all three of those things going on. And the issue, of course, is that these elements interact with one another and often exacerbate one another. You know, being in pain makes you tense. Tensing up exacerbates pain. That's one simple example. And so what they found in the Polytrauma Center in Tampa, where Tampa VA, where Walker and Clark and company are based, is that what they called it was resistant to treatment. But what they found was that responding to people who had post-deployment multi-symptom disorder, responding with a single treatment was really not going to work. Obviously, you have to take on the whole picture. So for us, we say complex pain requires a comprehensive response, and CPP clinicians jointly seek to address the physical pain, the emotional and spiritual distress, the relationship health, and substance use disorder issues. So I think that's the end of my lecture, and now we can look at the results of the research. So next slide, please. In the 9 months from June 2019 through March of 2020, when COVID-19 kind of shut us down, we trust, temporarily, the program served 6 cohorts with a total of 51 participants who completed the entire program and completed both the pre and the post surveys. Next slide, please. This chart covers just 45 patients because this data was captured before the 6th cohort had finished. But what it shows you, it's trying to answer the if you build it, will they come question. And so what you see here is the number of people who used each of the different therapies that we're offering over the course of those first 5 cohorts. So just bring your attention only to the bottom row, which is where the totals are. And those squares that are in dark green, they represent the PATH and the COMPASS groups. So those are the 2 required weekly groups. So they're high numbers. They also represent choice less than anything else because they are mandatory. If you look at the boxes that have the numbers in blue, which is medical visits and massage and craniosacral therapy, which is what I offer, and acupuncture and Reiki, those are all individual sessions. And the boxes where the numbers are in black, which is nutrition and yoga and PT/OT, those represent numbers that are combined individual sessions plus groups that go on, yoga classes or nutrition classes, you know, cooking classes, and group PT that's done sometimes. So in total, what we see is, looking at the lower right, is that across those 5 cohorts, those 45 people had a total of 1,361 therapeutic moments, you might say, therapeutic encounters of some course over the 8 weeks that they were there. On an individual participant level, that means that on average, I think you can give me the next slide now. On average, An individual attended 13 out of a possible 16 of the group sessions. And on average, they experienced 17 moments or sessions of other therapeutic sessions of whatever it is that they found useful or interesting, or whatever it was that matched their schedule. You know, we don't always know why people are making the decisions they're making. So that's a lot of therapy. What are we getting for it? Next slide, please. So of course we wanted to look at pain. And people rated these 3 pain-related measures on a 10-point scale. And as you can see, from the day of orientation, their orientation session, to the day of their graduation, the average pain dropped from 5.7 to 4.5. And the 2 measures of interference, pain interference with life enjoyment on one hand, and with general activities on the other hand, both had more significant drops. So we weren't dropping the pain so much as something about how people were dealing with their pain so that it didn't interfere with their lives as much. That's how it looks to me. We should keep in mind that these are tiny samples. This is very preliminary data. I show you the percentages, but we're more interested in simply direction at this point than in magnitude. Next slide, please. So regarding both resilience and self-compassion, the pattern again is the same, which we know is deeply related to your capacity to take care of yourself, and also your capacity to be kind to others as well. Both those moved in the right direction. You can give me the next slide, please. So across the 7 areas of inquiry that Promise 29 covers in physical health, mental health, and social health, and this is, I feel like I'm repeating myself, but it is the same thing. What we see is that everything moved, and everything moved in a positive direction. So we had decreases in pain interference and in fatigue, sleep disturbance, anxiety, and depression, and increases in both physical function and in people's capacity to fulfill their social roles and engage in activities that are meaningful to them. So seems like things are moving in good directions. Next slide, please. So then what are the takeaways? I would say with this very preliminary data, we can say in terms of feasibility that the partnership between the UVM Medical Center, between Blue Cross Blue Shield of Vermont, and a strong team of clinicians has allowed us to design and launch a transdisciplinary program for people with chronic pain. We got it, we built it, it's there. And for people with chronic pain who seem to be engaging with it pretty substantially and with a relatively deep degree of appreciation as well. So I would say the participant engagement is overall fairly strong. In terms of pain reduction, we reduced it very modestly, and we have yet to see what that even means when we get to a larger sample. In terms of quality of life improvement, everything has moved in the right direction. And again, when we have a larger sample, we'll be able to tell you more and with more confidence. And really the same for all the promise, everything moved in the right direction. I think what it means to me is that if everything is moving in a positive direction, we aren't just seeing noise in the system. We're seeing something that's happening. We're not at a place to perform any, no power analysis has been done. We're really dealing with small clusters of individuals. And we will know more as we pursue it. But I think that we could say that it's worth pursuing. On the basis of this data, we could say it's worth pursuing. It's worth investigating. That's my view. Next slide, please. So I want to say a comprehensive program is actually a hard thing to do. A complex program is a hard thing to do research on because it doesn't really lend itself to a reductionist model very well. And when I submitted the first article on Mission Reconnect, which is the program that I had developed also a complex program that, that my partner and I had developed for veterans returning from Iraq and Afghanistan. The publisher said to me basically, well, of the 14 things that people are learning from this program, which range from partner massage to a morning gratitude practice to therapeutic yawning to Qigong, of these 14 things you're teaching them, which ones of them account for the changes that you're seeing? Hit the next slide, please. And my answer to that is that it's the ones they used. We're not in a position to say something is more important in this program than something else. The question, this goes back to what Ben Kleekler was saying, what John was saying about what our goal is in terms of understanding what people's goals are, what their preferences are, and meeting them there in terms of what matters to them. When Tracy Gaudet was sitting in the seat that Ben Kleekler is now in, she said what she wanted to change was the key question from what's the matter to what matters to you. And it is that we're trying to emulate, and as we know, patient empowerment and engagement are key values in integrative healthcare. So I think that is my summary, and I hand it back to Kara, who's going to field questions. Is that right?
Amy, I see we only have 2 minutes. So can I just put one question in? And I think it's an important one, which is maybe towards John.
Kara?
Yes.
That's fine. If everyone can please just note that we do need our break because it's been so if we can get to 2 minutes for all of it, that would be great. Thank you.
Okay. One question. John, does the bundle cover our overhead costs?
Yeah, the bundle is designed to cover all the costs associated with the program, staff costs, clinician costs, expensive building renovation. So yes.
Okay, great. And Janet, maybe quickly, someone mentioned it looked like there was more activity with the passive modalities than the active modalities. How do you encourage people to do more of the active therapies?
Well, as a person who offers massage and craniosacral therapy, I would say that's actually, those are not passive modalities the way that I do them. And part of what I do and ended up doing with almost everyone, because almost everyone wanted it, was to have their partner come in and to do some training in, not in craniosacral therapy, but in massage and in Jin Shin Jyutsu techniques so that they could take things home, so that they still were going to have care as they got home. And also I attend to, to postural issues and taught people stretches and whatever. So I wouldn't call them really passive for the most part. And I don't know how much that's true, but I think the acupuncturist also does other kinds of coaching.
Okay. We actually have a lot more questions, which we will have to answer at a later time. So I think our time is up. So Vermont is out. Thank you, everyone, so much. Oh, yeah, and we have those events coming up.
Oh, yes, and thank you, all of you, so much. This was fantastic. You did a wonderful job, and we're sorry to push the Q&A, to after. We just, we know everybody needs to stretch, and we just want to make sure everybody's taking good care of their bodies as we have to start our next session in 10 minutes.
Okay.
And Kara and team, thank you all for agreeing to answer some of these questions. We've got a lot of great questions that came in, and we know that you have agreed to help answer those, and we will share them all with the recording for everyone. So again, to everyone who's attending, we really appreciate your interest and your questions. So keep them coming. And there's just so much good information. We didn't want to cut short on that. So it always goes a little longer than we expect. So thanks all. We are just going to take a brief break. We're going to resume at 5:30 Eastern for our final session. Stick around. This one is really exciting too. I think each one is just as interesting as the next, and we're really excited for you to stay on one more hour, and then you can celebrate until tomorrow. So we're having a great symposium, and we appreciate all your interest. So we'll see you in a few minutes. Thanks all.